Dear students, greetings of the day. I know you all must be very busy in your preparation for exams, both class and competitive. Today we will be discussing about an important aspect of pathology, a morphological unit known as giant cells. This is not only interesting, but also essential for your examination point of view and in diagnosis of many diseases. The very presence of these cells can give an important clue in differential diagnosis and also give a useful lead to arrive at a final diagnosis. The term giant means large or big. So these are unusually large cells formed by fusion of the several distinct cells. The cytoplasm of these cells coalesce and forms a syncytium of abundant pale eosinophilic to granular to foamy cytoplasm, in which are suspended the nuclei of these cells. This was first described by Virchow and Langhans. Depending on the amount of cytoplasm, quality of the cytoplasm, the number, size, shape, and location or pattern of arrangement of the nuclei, these cells are categorized in very many important types like foreign body giant cells, Langhans giant cells, Totten giant cells, and tumor giant cells. The classification of these giant cells are more or less known to each one of you. They can be divided into physiological giant cells like osteoclasts, megakaryocytes, and syncytiotrophoblasts. Pathological giant cells can be divided like any pathological condition into non-neoplastic and neoplastic. Non-neoplastic giant cells are of many types, but important of them are foreign body giant cells, Langhans giant cells, Warthin-Finkeldy giant cells, and Asop giant cells or Asop cells. The neoplastic giant cells are those which are present in benign or malignant conditions. The important ones of them are Totten giant cells and the malignant giant cells like RS cells and those seen in high-grade sarcomas and carcinomas. So we'll be discussing each one of them very briefly about the morphology, the function, and the location where they are present. Like you all know, physiological giant cells are those which are present normally in healthy individuals. These are osteoclasts, megakaryocytes, and syncytiotrophoblasts. The osteoclasts are present on the bone surface or in the endosteum. These are large cells of around 50 micron in diameter, have very abundant non-basophilic cytoplasm with azurophilic granules, and they contain around 10 to 20 well-separated nuclei, vesicular in nature. The function of these cells is the regulated breakdown or destruction of the old bony tissue. Now, coming to the megakaryocytes, these are bone marrow cells, very large cells of around 50 to 150 micron in diameter with abundant pale pink to basophilic granular cytoplasm and contain a large lobated nucleus with coarse granular chromatin. I must tell you here that all the giant cells are not multinucleated. They can be single with multilobated nuclei also, like you are seeing in this case. The purpose, the function of these cells is production of the platelets by a process known as karyokinesis. Now, the syncytiotrophoblasts are present on the outermost surface of the placental villi. These are terminally differentiated cells, very large in size. They have abundant eosinophilic to vacuolated cytoplasm with multiple dark or pycnotic nuclei. The function of these cells is to provide nutrition to the fetus through a process of feto-maternal circulation. And these cells are formed by the fusion of the cytotrophoblasts. Physiological giant cells, though found normally, there are certain conditions where these cells may be specifically present and will be an aid for us to diagnose those conditions. Coming to the osteoclast, the most common condition where these osteoclastic giant cells or osteoclast type giant cells are present are giant cell tumor. Certain non-neoplastic conditions like osteoporosis, rheumatoid arthritis, Paget's disease, and there is a list of giant cell containing lesions which you can remember by the alphabetic mnemonics A to G, or you can add up your own ones also. A stands for aneurysmal bone cyst, B for brown tumor of hyperparathyroidism, C for chondroblastoma, chondromyxoid fibroma, D for dermatofibroma, E for eosinophilic granuloma, F for fibrous dysplasia and fibromas, both ossifying and non-ossifying, G for giant cell tumor, which I have already told you. Now, the megakaryocytes are present in many conditions like ITP, myeloproliferative neoplasm, myelodysplastic syndrome, certain types of leukemia like AML M7, which you must have read in your hematology classes. This is otherwise known as megakaryocytic leukemia, extramedullary hematopoiesis, and reactive megakaryocytosis. In contrast to these two giant cells, the syncytial trophoblasts are seen in very few conditions, mostly those related to gestation, like gestational trophoblastic diseases, and certain extra-gestational tumors like germ cell tumors of choriocarcinoma or embryonal carcinoma type, where you can see the syncytial trophoblastic giant cells also. Pathological giant cells, like any other pathological condition, can be non-neoplastic or neoplastic. Now, the non-neoplastic ones are many in number and type. The important ones which we encounter in our regular pathology practice or studies are mostly foreign body giant cells, Langerhans giant cells, Askov giant cells, and Warthin-Finkelty giant cells. Coming to the foreign body giant cells, these are large cells of around 40 to 120 micron in diameter, having 100 nuclei present diffusely throughout the cytoplasm of the nucleus. These are mostly found in response to foreign body biomaterials like suture, keratin, bile, tattoo material, medical devices like prostheses, catheters, parasites, and their purpose is to degrade or destroy these foreign materials. And the location of these cells are in the junction between material and tissue or tissue material interface. This is a condition of cholesterol granuloma where these foreign body giant cells have engulfed the cholesterol granules. The Langerhans giant cells is the most discussed ones, and you are usually asked in the exam. These are large cells of 100 micron in diameter, have abundant eosinophilic cytoplasm, less than 20 elongated to ovoid vesicular nuclei, usually arranged in horseshoe pattern or in the peripheral pattern in the poles. They have inconspicuous nuclei, and the nuclei of these giant cells look same as the epithelial cells. That's how you can diagnose them. And these are found by the fusion of the epithelial cells. They are found in certain immune granulomatous conditions like tuberculosis, leprosy, syphilis, Crohn's disease, sarcoidosis, etc. This was first discovered by Theodore Langerhans in 1868. Asab giant cells, in contrast, are rarely seen. These are found in the Asab bodies, which are fibrinoinflammatory masses present or encountered in rheumatic heart disease, and they can be found in all three cardiac layers, but less frequently in the pericardium. These are 40 to 120 micron in diameter, though size is not very perfect, and contain less basophilic cytoplasm with around 4 nuclei. This is formed usually by a fusion of the Anetsko cells, which are modified macrophages, and this was discovered by Ludwig Asaf. Coming with another important giant cell known as Warthin-Finkelty giant cell. This was discovered by two scientists. So one is Warthin and one is Finkelty. One is German scientist and one is American scientist. These cells are around 100 micron in diameter, have very irregular cytoplasmic border, abundant less basophilic cytoplasm with around 20 or more than that overlapping grape-like nuclei containing viral inclusions, which are present both in the nuclei and also in the cytoplasm. They are found in the viral infective conditions like measles, rubella, and less frequently in HIV. Certain non-infective conditions like Kimura's disease and SLE also, these type of giant cells may be seen. And the location of these giant cells is in the germinal center of the lymphoid tissues like lymph node, spleen, and tonsil. Like I told, there are certain non-neoplastic pathological giant cell types which are less encountered or less studied, less commonly found. Those can be seen in infective conditions like epidermal derived giant cells, or otherwise known as giant cells, which are seen in viral infections like herpes simplex, herpes zoster, and varicella. The Jank cells are seen in vesiculobilous lesions of both infective and autoimmune origin. But the Jank giant cells are those where you encounter more than one nuclei, and they are seen in viral infections, like I told you. Now, there are certain viropathic multinuclear giant cells which are seen in viral infections like HIV and COVID-19, which you have already seen earlier. Now, in parasitic infestations like leishmaniasis, entamoeba, also you may see certain multinucleated giant cells. In the skin, nevi and all that, you may see melanocyte-derived giant cells known as starburst giant cells and balloon cells. There is a rare condition of the blood vessels of medium and large size, known as giant cell arteritis. This condition is characterized, diagnosed by seeing the characteristic presence of a granulomatous inflammation, which contains giant cells, and they are seen in the junction between intima and media of the blood vessels. Now, in the thyroid, as you have seen, there are many conditions, both benign and both non-neoplastic and neoplastic, where you may see multinucleated giant cells. Like they are Hashimoto's thyroiditis, de Quervain's thyroiditis, granulomatous thyroiditis, multinodular colloid goiter, and certain malignant conditions like papillary carcinoma of thyroid, anaplastic carcinoma of thyroid. Now, coming to the neoplastic giant cells, there are many epithelial and mesenchymal lesions, both benign and malignant categories, where we may get neoplastic giant cells. Now, out of them, a very well-studied and classic giant cell is known as Taunton giant cells, which are present or found in the benign mesenchymal lesions rich in lipid and cholesterol. These cells have a very classy look, which once you see, you can identify them. These are large cells with cytoplasm divided into two parts. The central part is eosinophilic, surrounded by a ring or wreath of vesicular round nuclei, and the outer cytoplasm is vacuolated. So the cytoplasm is divided into two parts, central eosinophilic and peripheral vacuolated. The central eosinophilic cytoplasm is surrounded by a wreath of this nuclei. This is Taunton giant cells, and they are seen in conditions like xanthoma, xanthogranuloma, xanthelasma, and dermatofibroma or cutaneous fibrocytosis, and certain conditions like fat necrosis. Now, the malignant epithelial and mesenchymal lesions also may exhibit presence of giant cells. The bright example of that is RS cells, which give a hint to the diagnosis of Hodgkin's lymphoma. These are the hallmark cell of Hodgkin's lymphoma and are essential for the diagnosis. So these cells are large cells of around 50 micron in diameter, like you can see in this picture, and they have the cell with the nucleus which is bilobed or binucleated, and each lobe has a prominent acidophilic nucleolus surrounded by a zone of nucleolar clearing or halo. This gives a very peculiar appearance known as owl eye appearance, and each lobe of the nucleus looks like the mirror image of the other one. They are found in the lymph nodes and derived from the germinal center cells. These RS cells can also be present in certain other conditions like infectious mononucleosis, anaplastic large cell lymphoma, and certain B cell non-Hodgkin's lymphomas. Besides that, we may see these tumor giant cells in certain high-grade carcinomas and lymphomas, carcinomas and sarcomas. The sarcomas can be osteosarcoma, rhabdomyosarcoma, sarcoma, and undifferentiated sarcoma. Carcinomas can be squamous cell carcinoma, melanoma, etc. I'll be telling you about these conditions. This is the look or the morphology of a tumor giant cell. Like you can see, the nuclei are very large, pleomorphic, hyperchromatic, containing a prominent nucleolus and coarse granular chromatin. I must tell you here that the nucleus of these cells look like the same of the mononuclear tumor cells. That is how we can diagnose that these are the tumor giant cells. So the tumor giant cells, which are seen in the malignant tumors of both epithelial and mesenchymal origin, are divided into two categories, like osteoclastic giant cells or osteoclast type giant cells and the tumor giant cells. Now, osteoclastic giant cells resemble the osteoclasts, and they are positive for TRAP. They can be seen in certain giant cell rich conditions or the giant cell variant of those conditions like malignant GCT, giant cell sarcoma, and giant cell rich or GCR, osteosarcoma, angiosarcoma, chondroblastoma sarcoma, atypical fibroxanthoma, certain undifferentiated or high-grade carcinomas like those of pancreas and urinary tract, giant cell rich melanoma, squamous cell carcinoma, metaplastic carcinoma, endometrial carcinoma, and hepatocellular carcinoma. These answers look like this. You can see they look same as the osteoclast, and that is how you can identify them. And the difference of them from the tumor giant cells is that in tumor giant cells, the nuclei are pleomorphic, hyperchromatic with prominent nucleoli. But here the nuclei are of same size and shape, and the chromatin is vesicular. Here you can see two types of giant cells. This is seen in this was in the osteosarcoma, and this is a high-grade carcinoma of serous type. You can see these giant cells. So students, we have almost finished all the types of giant cells. Now, before finishing, I must tell you about this one, which may come in your MCQ exams. These are known as floret-like giant cells or floret cells. As the name indicates, floret means flower. So these cells they look like flower with the nuclei arranged in a wreath-like pattern or in a linear pattern. These are derived from the stromal cells. That's why they are known as multinucleated stromal cells, and they are found in the benign stromal or mesenchymal lesions. To name some of them are neurofibroma, pleomorphic lipoma, giant cell fibroblastoma, and giant cell angiofibroma. These cells can be diagnosed by seeing the presence of immunohistochemical positivity for CD34. So I sincerely hope that you came to know about all the types of giant cells. You can remember and reproduce this in your exams and during your pathology practice and all that. So I have this acknowledgement for the images and also other for the images. So students, thank you. Thank you a lot for the patient hearing, and I hope you will sincerely go through this and remember everything. And have a good day and have happy studying and smart reading. Thank you all.